that shows a focal lesion in the upper pole of the transplant kidney, and that shows with the low ADC values. So this suggests to of a renal abscess, which is an infection, and in a post-renal transplant to suspect, what you will suspect in the post-transplant, you will be suspecting an aspergillosis. So this was an aspergillosis. What is this? This is a can be focal, the focal mistaken for a renal tumor. So you can see the enlarged kidneys with fat within the renal pelvis with multiple calcifications. And if you do a CT urogram, and you will see the typical bad spot appearance after contrast. So this is what is called as a Dixon image. It has a water suppression. So there is a focal lesion here. Anybody is able to see which side, right or left? So left you are seeing a lesion. This is a water suppressed image. This is an in-face image. So you see the lesion which is hyperintense in the left side. This is an opposed face image, and you can see it is suppressed. So what is it? That's a small angiomyolipoma. Very good. So the Dixon image is very useful to pick up very tiny lesions, fat-containing lesions like this, and this is the CT that you can see the fat-containing lesion here. So incidentally, we may pick up lesions even when they come for a routine MRI abdomen, which is an incidental, it may be a small benign lesion. So this renal lesion that has a typical stellate-like appearance in the post-contrast scan. What is this? It's a renal oncocytoma. So the renal oncocytoma scar, and you can see that it's a well-defined lesion with the central stellate scar. The scar appearance, based on the scar, it has been classified into various types: a stellate type 1 or type 2A or type 2B, and type 3 appearance based on the type of enhancement of this scar. So the criteria to diagnose a renal oncocytoma is in the nephrographic phase. There is a hypodense scar tissue. The scar may be stellate or polygonal. It has homogeneous attenuation with no calcifications or hemorrhage, no signs of metastatic disease. So, and this is a lesion which is seen in the oncocytoma can also have cystic changes in this, like what you see here. So we have to keep in mind that sometimes a confident differentiation from RCC cannot be made if, since the central necrosis in RCC can mimic sometimes the central scar of an oncocytoma. So a reninoma is a rare tumor, and the clues to suspect a reninoma may be a lesion which is hypertense, a lesion which is seen in women who present with hypertension or hypokalemia. Then we have to suspect a reninoma. So this is a large lesion in the right side. Again, it's a fat-containing lesion with the subcapsular areas of hyperdensity. So this is a angiomyolipoma of the right kidney, and patient presented with hematuria. So you can see the multiple areas of fat-containing lesions with also there is a subcapsular areas of collection with hemorrhage. So again, you have to keep in mind sometimes a renal cell carcinoma or nephroblastoma in children can contain small amount of fat, and one should never mistake the engulfed fat tissue of the renal sinus in RCC. Whenever there is fat and calcification, then it is suspicious for carcinoma, since AMS do not have calcifications commonly, and there is no invasion of the renal vein. So having seen some tumor mimics and some benign renal lesions, we'll go on to the most common pathology, which is the malignant focal lesion, which is the renal cell carcinoma. So in the renal cell carcinoma, we have to know the types, and we know the modalities and the staging and the follow-up. The most common type is the clear cell type, which is 70%. Papillary and chromophobe types are less common. The clear cell type shows contrast enhancement, which is usually more than 15 to 20% above the baseline, and the papillary cell type is usually relatively hypovascular. The chromophilic cell type is a tumor which may be commonly bilateral, and they show relatively low ADC values. So the enhancement in clear cell type enhancement is more than 15 HU. Chromophilic is relatively hypovascular. The papillary type of renal tumor is commonly bilateral and multifocal, and again it can be relatively hypovascular. And we have to do a delayed image as part of a protocol, since contrast enhancement may accumulate relatively late in case of papillary renal cell carcinoma. So for the staging of RCC, generally a multiphasic CT with MR modality may be useful for characterization and staging. And MR may be useful, especially the ADC values, to differentiate the various subtypes of RCCs. So earlier there used to be done IV urogram, intravenous urogram for the kidney. So this is an example of renal cell, when the which side the abnormality is, it's in the right. So the left renal nephrogram is normal, calycid excretion is normal. If you see in the right side that upper pole, you are not able to see the nephrogram, and you can see there is a distortion of the calyces. So whenever you see a distortion of the calyces with the non-opacification of the nephrogram, you will suspect malignant renal tumor. If there is smooth or splaying of the calyces, then you will suspect a renal cyst in urogram. So this is the axial CT images of the patient that showed a mass lesion involving the right kidney. So this was a large, it is an MRI that shows T2-weighted image and ADC values and the T2-weighted that shows a large lesion occupying, involving almost the entire left kidney with a heterogeneous appearance. There is also invasion of the left renal vein. The coronal image that shows the lesion that is involving almost the entire left kidney. And this is a patient who had a renal cell carcinoma with cystic change. Patient usually present, this patient presents with hematuria and a left varicocele, which is one of the presentations for an RCC. So this is CT urogram that showed a heterogeneous lesion which is seen in the left upper pole with obliteration of the calyces, and the corresponding multiplanar coronal image that showed the patent renal vein without any thrombus, and the arteries are seen. So in whenever MDCT can be used to provide a one-stop imaging like MR, which can be seen the renal veins, arteries, and the CT urogram that shows the non-opacification of the calyces in the left upper pole. So what you have to remember is that a solid renal mass is malignant unless it is proved otherwise. Enhancing renal lesions may be seen with the renal cell carcinomas, oncocytomas, or leiomyomas, or AML. Generally, a threshold of 15% enhancement over baseline pre-contrast is helpful. A decreased signal opposed phase imaging can be seen with renal cell carcinoma, sometimes due to the presence of lipid whenever the mass is quite large. So this is another patient who had a large lesion involving the right side. This is a coronal stir image MR with small hyperintense lesions in the liver, so this is liver metastasis, and this lesion is also extending into the IVC. So this is the post-contrast subtracted imaging that shows this lesion to be relatively hypovascular, and this is the MR angiogram, contrast against MR angiogram that shows the vessels are relatively sparse and it's not relatively hypervascular. As I say, MR urogram that shows the non-visualized or the non-excretion in the right side of the kidney. So this was a relative chromophobe type, and this is someone that had liver metastasis. Variant is relatively hypovascular compared to the clear cell type, which is the commonest type of RCC. So as I mentioned before, diffusion-weighted imaging in renal focal renal lesions and renal tumors can be useful to differentiate RCC and TCC. The transitional cell carcinomas will have a relatively low ADC compared to the RCC. The mean ADC for clear cell renal cell carcinoma is relatively higher than for a papillary or chromophobe RCC, which means what does it mean is that the restricted diffusion will be more in case of a papillary or a chromophobe type of renal cell. This is another involving the left renal upper pole, stir images, which is appearing hyperintense. You can see there is significantly low ADC values, which is very lower compared to what is a normal clear cell type. And the coronal, post-coronal stir images and the T2 images that shows the infiltrative lesion. So this was found to be a papillary renal cell carcinoma. So the papillary renal cell carcinoma has significantly low ADC values compared to a clear cell type. So moving on to whenever you see a focal lesions, and useful for studying is the PNM classifications. So generally in any renal tumors, what focal lesions, especially in renal cell carcinomas, you have to know about these, report the size of the tumor, the renal localization, whether the tumor is anterior, posterior, or lateral, because sometimes the laparoscopic surgeon may intervene to do some surgeries, whether it is deep or superficial and protruding into the renal contour and distance from the renal collecting system. So again, we have to mention about the arterial anatomy, whether what is the number and whether there is any peritumoral vascularization. Since large tumors could have collateral vessels, which is a contraindication for laparoscopy, report on the venous anatomy and the variants. So before we conclude a report for RCC, what we have to report is what the urologist needs. He needs to know whether there is an extracapsular invasion or the perinephric invasion is there. Renal vein invasion, as in this case, you see a renal vein thrombosis, which is seen extending to the IVC. Presence of any lymphadenopathy, tumor thrombosis is a bland thrombus. So if you know that bland thrombus does not show a restricted diffusion, whereas a tumor thrombus shows a restricted diffusion, tumor thrombus will show contrast enhancement, and a tumor thrombus will show uptake in PET CTs. So these are the ways to differentiate a tumor thrombus versus a bland thrombus. So the relationship of the tumor to the collecting system has to be assessed, and since the urologist want to obtain a margin of 1 centimeter normal parenchyma, which is deep to the resected tumor, and what is very important to remember is that whenever there is, you have to report on the local invasion to the paraspinal musculature in any case of renal tumor, malignant tumor. If there is involvement of the iliopsoas muscle or the abdominal wall, the tumor is unresectable, which is based on imaging alone. And the invasion of the vena cava wall has also to be reported. We know that the IVC thrombus is there, but if there is a pericaval tumor extension or inflammatory reaction, which means that this has a worse prognosis and may need a vascular replacement during surgery, then we have to report whether the hepatic vein confluence is involved, since there is a crucial level of IVC extension, and the tumor thrombus extending below this level will need temporary interruption of hepatic blood flow. And so this is again a tumor that has relatively low ADC values, and this was an adult Wilms tumor that we had, which is an 18-year-old boy, which was proved to be an adult Wilms tumor. So Wilms tumor can not only occur in the pediatric age groups, but can occur in the adolescent age group as well. So moving on to some other lesions, and here you see a focal hypotensive lesion in the kidney, and it was soft tissue density lesion. So besides that, you also, what do you see? You also see bilateral perinephric soft tissue nodules are there, bilateral perinephric soft tissue nodules, and in the same patient chest, you will see there is soft tissue thickening in the subcarinal regions. So this was a case of lymphomas. So whenever you see bilateral perinephric soft tissue thickening, the common differential diagnosis may be, if you see cystic changes, it may be due to renal lymphangiectasia, which is benign, or in case of children, you will think of nephroplastomatosis. In the adults, you may think of either of a lymphoma or a metastasis, or sometimes even extramedullary hematopoiesis. So this is the same patient that CT urogram that showed relatively good excretion of contrast with only the perinephric extension of the tumor. So renal lymphomas can present either as a focal lesion, or it can present as multiple lesions, or there may be a contiguous extension from the adjoining lymphadenopathy. So this is you see a bulky lymphadenopathy which is lifting up the aorta, which is called the aortic drape sign, with contiguous involvement of the kidneys. With you can see that the post contrast, you can see chelicid excretion is normal. So this is a renal lymphoma with contiguous involvement from the abdominal lymph nodes. And here again, this is the MR of the patient that shows the aorta is being displaced anteriorly. The same patient was seen in CT, and there is involvement of the kidneys by contiguous extension. The diffusion imaging shows significantly low ADC values. So diffusion imaging is also useful to assess in the follow-up of tumors to response after chemotherapy, especially in cases of lymphomas, where the ADC values can be useful as a biomarker to assess the response to chemotherapy. So in any patient who has a lymphoma renal tumor, we have a baseline ADC values which may be useful for response later on. And this is the coronal images. Besides the kidney, you can also see adrenal lesions are there. So this is a lymphoma that involves both the kidney as well as the adrenal glands. Bilateral adrenal gland involvement is there due to lymphoma. This is another case of non-Hodgkin's lymphoma that shows multiple hypotensive lesions, which is seen in the CT urogram image with multiple retroperitoneal lymph nodes. Corresponding MR image also shows the lesions, which is seen in both renal parenchyma. And this is called as an MR fusion image, where we fuse the T2-weighted image and the diffusion-weighted image. So in case of any follow-up or any oncology, fusion imaging is very useful to make the lesions more conspicuous. And this being wherever the software is available, we can just fuse the T2-weighted image and the diffusion-weighted image to assess the extent and also to delineate the lesions more clearly. So then moving on to some other lesions, transitional cell carcinoma can commonly occurs in the renal pelvis. So to differentiate, and sometimes there may be a difficulty to differentiate whether it's an RCC or PCC if it is centrally located. So the transitional cell carcinoma occurs in the renal pelvis. They have a centrifugal extension in contrast to RCCs, which extends from the cortex to the renal pelvis, which is a centripetal extension. So this is a CT image that shows a soft tissue density lesion in the renal pelvis. There is also another, this may be multifocal, commonly another lesion which is seen involving the bladder as well. Another patient who had hematuria, and this is the MR that shows a lesion within the left renal pelvis. And this is the T1 weighted in-phase image that shows the hypointense lesion here. And in diffusion rate imaging, as I mentioned before, transitional cell carcinoma has significantly low ADC values with restricted diffusion compared to RCCs. So that's a lesion that shows significantly restricted diffusion with low ADC values. So this is another, I just wanted to show this case which is quite interesting. And this patient actually was referred for MR spine for the back pain. And in the spine imaging, what you see that there is a bone marrow infiltration, and you see some soft tissue thickening here, and there's soft tissue thickening with bone involvement. And you could see that there is some, these are suggestive of lymph nodes, these are the coronal images here, and these are the axial images here. So what do you think? What is this? That's a horseshoe kidney. So this is a tumor, renal cell carcinoma within a horseshoe kidney that is seen within the renal tumor with the right renal lower pole that has caused lymph nodal metastasis with also bone marrow invasion as well. And you can see that this is the tumor within the right renal lower pole, and the isthmus left kidney appears normal. And this is the same patient that shows diffusion mirrored imaging, and the stir images multiple hepatic metastasis were there as well. So the horseshoe kidney is more prone for renal cell carcinoma, and this patient actually presented with back pain due to the involvement of the vertebral bone marrow. Moving on to some role of PET, and the PET is useful to evaluate in the follow-up of renal cell carcinoma, since most RCCs do not show much of FDG uptake, and you can see there is an enlarging cause of enhancement should be suspected for tumor recurrence. So this was a patient who had come for follow-up, and you could see there are some renal lesions that show uptake, and there is also uptake which is seen in the liver. So this was a suggestive of tumor progression, and you can see that PET uptake in the portal vein as well, which can also be used to differentiate the tumor thrombus. And this was suggestive of a progressive disease after therapy with multiple hepatic metastasis with thrombosis. So this patient had a left nephrectomy done. Patient had multiple lymphadenopathy, which is seen involving the left postoperative bed, and CT scan was also showed some bone metastasis. So RCCs, CT scan is useful to follow up RCCs, and the corresponding PET image that showed significant uptake in the lymph nodes, as well as a small left adrenal nodular lesion that was showing an uptake. So before I conclude, we have to know that cystic lesions are very common. They are appearing hypointense and hyperintense in T1 and hyperintense in T2 weighted imaging. And this is a lesion which is hyperintense in T1. So this is a hemorrhagic cyst, and this hemorrhagic cyst with gradient may show blooming. In any case of hemorrhagic cyst where there is a suspicion of tumor or there is hematuria, we have to always do a post-contrast subtracted imaging to differentiate spurious enhancement from a real enhancement. So just like in the brain, a post-contrast subtracted imaging has to be done whenever you see a lesion in the kidney which is hyperintense T1, especially in patients who have either a polycystic kidney disease or just a simply ordinary patient who has hematuria. Again, there is another cystic appearing lesion on the right. It looks quite complex with a slightly thickened capsule, and again this is appearing hyperintense in T1, and this is a complex cyst which should not be mistaken for a tumor. So to conclude, whenever you see renal lesions, common fat density lesions are the angiomyolipomas. Sometimes fat can be seen in RCCs due to the engulfing of the fat, also in xanthecal pyelonephritis. A stellate renal scar is not specific for oncocytoma, can be seen with RCC as well. MDCT is presently the modality of choice for focal lesions, especially RCC. Diffusion mirrored imaging has a role in evaluation of focal renal lesions. PET-CT is useful for mainly tumor recurrence and whole body evaluation. Thank you all once again.
Thank you, sir.